Pulse palsy and neuronal linkage. Imagine waking up one morning and suddenly one side of your face refuses to move. Your smile becomes uneven, your eyes cannot close properly, and even small and simple expression disappear. This is Bell's palsy, a sudden paralysis of facial muscles caused by dysfunctioning of the facial nerve, also known as cranial nerve 7. Hi, my name is Dr. Vaz, and today we're going to discuss uh, Bell's palsy and neuronal linkage. Bell's palsy is an acute idiopathic peripheral facial nerve palsy involving cranial 7. Epidemiology 15 to 30 per 100,000 person per year. Onset of course 48 to 72 hours depending upon which is responsible for the development of Bell's palsy, either injury, either virus, or any other thing that are involved. Clinical presentation, uh, lower motor neuron signs uh, like loss of nasolabial fold, drooping mouth, corner, rolling, hyperacusis, altered taste, and reduced hearing. Upper motor neuron versus lower motor distinction, motor neuron distinction. Uh, Bell's palsy is always caused by lower motor neuron. Uh, in comparison, human is involved in stroke and other diseases. House Brackman grading, that is grading used for the uh, grading of the Bell's palsy. Differential diagnosis, we have to exclude stroke, Ramsay-Hunt syndrome, Lyme disease, acoustic aneurysm, parotid tumor, GBS, sarcoidosis, and otitis media complications. Etiology, of simplex virus in the geniculate ganglion is leading proposed cause of Bell's palsy. Other viruses also involved Bacillus zoster and Epstein-Barr virus. The viral infection causes viral inflammatory response, targeting facial nerve myelin and destroying it, causing the nerve to be exposed and degenerated. Vascular and ischemic microvascular ischemia, vasospasm theory, and diabetes mellitus may uh, causes the Bell's palsy, and the risk increases by 2 to 4% in the people with diabetes. Risk factors: pregnancy, diabetes mellitus, metabolic or vascular risk factors, upper respiratory tract infection, and family history. Disease mechanism: HSV1 reactivation, viral reapplication and inflammation, nerve edema and swelling, entrapment in fallopian canal, compression-induced ischemia, conduction blockage, and facial muscle paralysis. Anatomical vulnerability, that is including the fallopian canal, inflammatory edema, and compartment syndrome uh, may also causes the Bell's palsy, and activation of TNF alpha and IL-6 for the inflammation. Secondary vascular compromise, vasa nervum is including that. This ischemia compound is chronic causing compressive injury. Demyelination and versus axonal injury. Mild cases show neuroplaxis, full recovery in weeks and maybe in months without any treatment. Geniculate ganglia as viral reservoir uh, that causes the cranial salmon injury. The normal mechanism, motor cortex, facial nerve nucleus means pons, internal acoustic meatus, geniculate ganglia, that is the site where HSV1 virus grows, tympanic and mastoid segments, stylomastoid foramen, facial muscle motor output to the muscle of expression. Neuronal mechanism, Schwann cells and myelin sheath injury, and the response is from the inflammatory markers like TNF-alpha and IL-1, exoplasmic transport disruption, neuropraxia versus axonomatosis, aberrant axonal regeneration and synkinesis, geniculate ganglion neuronal injury. HSV1 virus is the responsible for the injury of geniculate ganglia. Neuroinflammatory microenvironment, inflammation, edema, ischemia, that is due to the activation or uh, development of viral segments in that area. Diagnosis, clinical diagnosis, Bell's palsy remains a clinical diagnosis of exclusion based on history. Key finding, the motor neuron facial weakness involving the forehead, distinguished from upper motor neuron that is involved in stroke, House-Blackman grading, neuroimaging, MRI, contrast, and CT, electrodiagnostic studies, ENOG, most useful in severe cases, House-Blackman 5 to 6 to guide prognosis and surgical decompression decision. Laboratory and serological testing for the Herpes simplex virus and Versicolor zoster and any other viruses that is involved in the development of Bell's palsy. Ophthalmological assessment, treatment, corticosteroids, antiviral therapy, eye protection, physical therapy and facial rehabilitation, surgical decompression, it's very rarely used, management of long-term squeal, botulinum toxin injections, facial reanimation, surgery, psychological support should be there for the patient. Prognosis, early phase, week to month, and long-term squeal. 0 to 72 hours, 2 to 3 weeks, 3 to 6 months, and above than 6 months. Poor prognostic factor, complete paralysis, old age, diabetes, severe pain, delayed treatment is including the poor prognostic factors. That is summary. HSV1 virus, House-Blackman grading, anatomical bottleneck is the key. Early steroid